Well, thank you very much, Madeleine. Colleagues, I would like to take this opportunity and greet you all this afternoon. And please do forgive me. This is my first attempt into actually being involved in this platform. But let me just introduce myself for the sake of time, and I welcome you all. My name is Dr. Nkqubela. I'm a member of the executive of RuDASA and currently serving as the acting CEO at Grace Hospital in Pietermaritzburg. So it gives me great pleasure to be part of this onboarding program this afternoon. But before we begin, I would like to take this opportunity and remind you that RuDASA, which is a Rural Doctors Association of South Africa, is an organization that provides networking, support, and advocacy for clinicians working in rural facilities, as well as those who are passionate about rural health service delivery. Membership is free and gives access to our learning portal with a wide range of resources useful to rural healthcare clinicians. So to join, you can just easily go to our website at www.rudasa.org.za. But let me also remind you that all of our webinars that we run are actually recorded and will be available at our RuDASA YouTube channel at www.youtube.com/@ruraldoctorsasa if you would like to also get the previous YouTube webinars. Now, I would like us to first just start with some house rules, if we may, just to please ensure that your microphone is off during the presentation. We encourage you to also keep your questions until the end of the presentation. Alternatively, you may use the chat box to type your questions during the talk, and we will get into it at the end of the presentation. Or if you would like to ask a question at the end of the presentation verbally, you can please raise your hand and we'll recognize you and invite you to unmute and place your question. So now, let me then introduce our speaker for today. Dr. Madeleine Muller is a family physician at Cecilia Makiwane Hospital in Mdantsane, and she is a senior lecturer at Walter Sisulu University. She provides clinical services and teaches and mentors medical students, registrars, as well as medical officers. Dr. Muller graduated with a master's in health professional education from Stellenbosch University in March of 2025. Dr. Muller is a convener of the CMSA Diploma in HIV Management, and she also serves on the National CMSA and Succumbed Committee, which is responsible for implementing workplace-based assessments in postgraduate medical education in the Southern Africa. Dr. Muller is part of the CMSA and SAAFP team rolling out the supervisor workplace assessment and teaching training for clinical supervisors across the 10 South African medical universities. While Dr. Muller as well is on the steering committee for the South African Association of Health Educationalists Eastern Cape chapter and is an executive committee member of the Rural Doctors Association of the Southern Africa, where she oversees the mentoring portfolio and manages the rural onboarding program. She also serves on the executive board of Professional Association of Transgender Health in South Africa, with a strong passion for inclusive clinical care, sexual and gender health, and medical education. Dr. Muller is dedicated to curriculum development and fostering the growth of emotionally competent, patient-centered clinicians. Now, please allow me to welcome Dr. Madeleine Muller to give us their presentation for tonight. So over to you, Doc.
Thank you very much, Dr. Nkqubela. I'm hoping that I'll try to keep the video on for a bit. I'm quite expressive when I teach. Unless I see my bandwidth gives trouble, then I might switch it off. Let me just grab my presentation. So the reason why I'm actually teaching this particular presentation, which is on mood disorders with severe distress, is that we are trying much more to include mental health topics. So one of the challenges is quite often the rural onboarding program and the ramp, we have a very heavy sort of towards the more sort of, emergency medicine, adult medicine, child health topics. And we're trying to build in more and more mental health capacity, especially because most district hospitals do not have easy access to psychiatric or mental health services. And so if you are a medical officer working in a district hospital setting, or if you're a general practitioner, quite often you are the one that actually have to diagnose and manage these patients. But we do find that there's sort of a particular stock standard presentations coming through, managing the aggressive patient, for example, or just looking at your sort of standard mood disorders. And what we've recently found at Cecilia Makiwane, where I'm working, is that we've recently taken on the 72-hour 72-hour ward from internal medicine. And so I've been creating specific, looking at like sort of different aspects of managing mental health. And one of the challenges we have when we are looking after our mental health patients is that we quite often have to deal with patients with mood disorders. So people are not psychotic, people who do not necessarily have, for example, an acute psychotic event, but people who are just, for example, potentially high risk of suicide, or people presenting with, for example, bipolar. And both of these topics are not very well covered. And a lot of people do not necessarily feel confident in how to do, for example, an assessment in terms of suicide risk, or how to manage a manic patient. So I'm going to be focusing in very closely just on those two actual types of scenarios within the broader understanding of depression and within the broader understanding of bipolar. And so you'll see I've sort of going to be very targeted in how we're going to talk about this. So when you look at any mental health disorder in the EML, they talk about certain risk assessments we need to keep in mind. And that's partly what made us decide to also do this talk. And we actually have to be able to make a clinical judgment for potential of various things. So this includes suicide or self-harm. It includes aggression or violence of our patients potentially towards others. But it also looks at patients who can potentially be vulnerable. So their vulnerability of being either assaulted by others, high-risk sexual behavior, as we sometimes see with our manic patients, severe self-neglect or actually being exploited, reputational damage, patients obviously not adhering to treatment because they have no insight of the importance of having to take it, causing damage to property or actually affecting their physical health. And there's quite a lot of our mental health patients that are actually very vulnerable, even though they might not be floridly psychotic. People we want to pay particular attention to is our women in perinatal period, who are much more vulnerable, especially with the mood disorders. And they're obviously also taking care of a small baby at the same time. And so therefore we need to be very careful with our pregnant women, our women in the perinatal period, and anybody who's actually caring for somebody else. So if we think of our carers, if a carer looking after a fragile elderly person develops, for example, a mania or a psychotic disorder, then that can potentially put other people around them at risk as well. So what I'm going to start off with is, when we talk about diabetes, we have to talk about insulin. When we talk about mood disorders, we have to talk about emotion. So I'm at the moment in my pre-doctoral year for my PhD. I'm busy working on my proposal, and I'm going to be looking at researching how to teach emotional competence to doctors. Not that we already have a certain amount of emotional competence, but you need quite advanced skills, I think, as a medical doctor in terms of dealing with emotion. And this means that all my reading at the moment has been on emotion. And I'm going to take a little bit out of that conceptual framework that I've been working on, because I find this model is quite useful also when we think in terms of managing people who are struggling, for example, with mood disorders. So those of you who've seen some of my other talks will be very familiar with this system. And the idea is that as human beings, biologically, emotions have a very important role, and emotions is part of our survival system. So we have a survival system that's made up of our limbic brain, our endocrinological system, and that includes ways to try and keep us safe until we've eventually reproduced and raised some kids, right? That's the sort of purpose of genetics. And it's not a very intelligent system, but it's based on very basic instincts and drives. So we've got a fight, flight, freeze, fawn system to try and keep ourselves safe from threat. And then we also have particular drives, for example, towards food, towards safety, towards intimacy, etc., to try and ensure that we stay alive. So the way our body gets us to do these things, follow these drive or avoid these threats, is through emotions. And the idea of emotions is they're trying to make us do things. So especially if the fight, flight, freeze, fawn system has been activated, there are three primal emotions. So these primal emotions obviously can be cognitively extended into a whole host of complex, beautiful, colorful, different emotions, but biologically, it all boils down to three. So firstly, we have rage, which is the biological impulse to destroy an obstacle in your way. I'm sure you've all felt and been at the receiving end of that on Friday night, an accident and emergency. Fear is the biological impulse to run away or to avoid something. And then the one we're going to talk about quite a bit just now is distress, the biological impulse to cry out. And I will unpack that in a moment. I also just quickly wanted to show you the three positive emotions. So the three negative emotions is when the survival system is in predominance. But if the survival system is calm, we have these emotions that belong to our biological system, but they can actually serve our prefrontal cortex and our executive brain. And this includes care, that's the biological impulse to nurture or take care of somebody or to be taken care of. Play is our biological impulse to interact with the world, to do things for the sake of doing it. That's all our hobbies and art and craft and sport. And seek, so what we're doing this evening, is the biological impulse to explore, to learn, and to problem solve. So these basic primal emotions then become secondary complex emotions. So you can get all kinds of, like jealousy is a good example of an emotion that can have either rage or fear or distress or a combination of those. But if you are within one of these positive emotions, then we have also this higher abilities of our executive system, including things like tolerance and empathy and gratitude. What's interesting is that these are impulses that's trying to get us to do things. And particularly these impulses have been designed around surviving physical threat. But these are not always very useful if we use them in relationships. So particularly the negative, the undesirable emotions. So if you're in a state of rage or fear or distress, you might criticize, you might manipulate, you might overly worry. You might feel very sorry for yourself. You might avoid something. And these behaviors quite often make a scenario worse. If, on the other hand, we're able to engage our executive brain and we're therefore able to engage some of these positive emotions, we have these extraordinary qualities that makes us human, that becomes possible. So for this very little philosophical conversation here, if we want to understand why the world at the moment is as nuts as it is, why things seem to be going sideways on a large scale on our planet, you can see it's because as human beings at the moment, we are predominantly operating out of our survival system, and it's rage, fear, and distress that's causing all of these challenges. Let's get away from the philosophy and let's just look at distress or grief. So the primal emotions we actually share with the animal kingdom as well. And each of these emotions have a purpose. So rage is to fight something, fear is to flee away from something, and distress, grief is an emotion that's there to help us get help when we are potentially abandoned or lost. So to use the example of a small animal, so if you imagine a small animal whose parent has wandered away, or think of a 2-year-old toddler in a supermarket who can't see its mom. And what nature's created is a biological impulse and to make this little creature cry out, wail, literally. And hopefully this will make the mother or make the carer come and return to that child. So the way nature's designed it, not very intelligently, is to be able to get you to cry out. It creates an experience of intense emotional pain. So both rage and grief doesn't cause nearly so much it doesn't really cause pain as such. It's a different kind of emotion. And this will get triggered by any loss. So if you want to think and reflect a little bit in your own life, if you've had a bereavement of somebody that you really cared about, or you had a bad breakup of either a friendship or a relationship, or even if you're in a scenario where you got rejected or you failed really badly at something, it would create this horrible feeling of emotional pain. And it's actually quite a toxic feeling. And it can initially lead to floods of tears and actually wailing and sobbing in distress. But actually it can get to a point that, say, for example, the carer doesn't return if the 2-year-old ends up staying in the supermarket or the little animal does not find its mother. It actually goes into a state of panic or shock where they actually slightly dissociate and sort of a freeze response that comes in. And that in itself can lead to particular behaviors. So when we talked about rage, that's obviously people who are stuck in rage, where you'll see all of your aggressive sort of disorders or issues. People who get stuck in a fear state, that's obviously all of our anxiety disorders. And people who are in depression or get something like a major depressive episode are people who are to some extent stuck within this distress state of emotion. So as I've said, emotions are a biological impulse. They're trying to get you to do something and not necessarily rationally. And there's three behaviors that concern us, particularly around distress and grief. The first one is obviously suicide or attempting at suicide. And I know sometimes people talk about attempting at suicide as just a call for help. I don't like the word just. That's exactly the point of it. When somebody is attempting to commit suicide, it means that in that moment in time, they are in such extreme pain that they are unable to manage. And actually that action is hopefully, if they do not manage, that somebody will come and assist them and help them. So it's quite an important way of somebody to actually try and re-find connection at a very sort of unconscious, guttural level. The other behavior that we say as self-harm or any sort of self-destructive behaviors, and we see this particularly, so not all eating disorders, for example, is necessarily due to distress, but self-harm often is due to somebody who's in that shock apathetic state. So they've become completely disconnected from people around them. They actually have an inner experience of feeling numb or feeling trapped within their own bodies. And by self-harming, for example, cutting or hitting their head against a object or punching a hand into a wall potentially, all of that is ways to try and actually reconnect with their own bodies and with their own feelings. And then substance use is particularly interesting. So if you think about that child in the supermarket that's lost, and the mom will come and find the child and pick the child up and give it a big cuddle, at the moment that the mom finds that child and envelopes that child, it actually creates this beautiful emotion of care and of nurturing. And in that moment, the child actually gets flushed with oxytocin and gets flushed with endorphins. So there's actually this physiological relief at finding the person that you were looking for. And that's actually, if you want to think of the perfect way to manage distress, would be somebody actually that you care about and that you want to obviously hug you, but to actually give you a hug when you are upset and giving you support. So what's also interesting is, so particular substances can fake or can also modulate, working on the same receptors, can also modulate that experience of emotional pain, particularly opiates like your codeines and your oxycodons and alcohol. And alcohol and benzos. Sorry, I've got my benzos on there. So those three substances all have a temporary effect of actually reducing that feeling of emotional pain. And of course, the risk is that somebody is already disconnected, feeling somehow not able to connect with people around them or not able to get out of this extreme feeling of distress, will end up using substances like opiates or benzos or alcohol to actually try and manage that emotional pain. When we talk about dealing with substance abuse disorders, when you therefore want to try and get people off those substances, if you haven't found a way to help them manage this distress and help them manage to reconnect with those around them, then actually they're not going to cope without those substances, who's actually providing relief for this intense emotional pain. So I'm hoping that gives us a little bit of a feeling of what we're managing when we have people presenting in such states in our hospitals. So let's just focus a little bit on depressive disorders. And I am going to talk about the whole management of depression, but I'm going to be quite selective in terms of focusing specifically on the risk side of it. So the DSM-5 diagnosis talks about major depressive disorders and dysthymia. I'm not going to talk about dysthymia at all today, but it's got a very simple definition. It's one or more major depressive episodes. You can get single ones or recurrent. I'm not going to focus on the DSM criteria here at all. So on my last slide, I've got a QR code and I've got various tutorials on this that goes into the DSM classification in detail. But I'm going to just talk about the PHQ-2 as our way to diagnose it. So just to remind us that it's quite a high percentage of our population, 7%, is almost 1 in 10 people will at some stage suffer from a major depressive disorder. Often occurs in the mid to late 20s, but can obviously occur at any time. Sometimes it can be quite sudden, or it might come up gradually. And important is that a major depressive, if you don't treat it at all, if you do nothing about it, they usually last on an average of 6 to 9 months, and then they go away. So depressive disorders, and we don't really understand this, is something that has its own, usually it's not something that if you don't treat it, it goes on forever. The antidepressants, therefore, is something that provides relief from that pain for a certain period of time and help people cope with that time. So important is that although we talk about depression, people experience these emotions differently within their bodies. And some people are not going to tell you about, oh, I'm feeling a depressed or sad feeling, but it might come up as other things. So for example, this loss of pleasure or reduced interest in their usual activities, including, for example, sex. Crucial to diagnose is that the episode must represent a noticeable change from the usual level of functioning. So as human beings, we all have times where we are more distressed, depending on what's happening in our lives, or sometimes we just go through a bit of a flat period. But if we can we can still manage our lives and we still have times and things in our lives that are enjoy, then that's not classified as a major depressive disorder. So I'm hoping most of you have seen or maybe come across the PHQ tool. I'm going to very strongly recommend that you please get familiar with it, have it on your desk, use it every day. For those of you that are not so familiar with it, the PHQ-9 are 9 questions. They're basically based on the DSM, so you can use this to make your diagnosis. And what's great about it is that the first 2 questions we call the PHQ-2, and if you just have to remember those 2 questions, and that's a good way to screen patients. So any patient who drops a Q, or if they're not managing, or they're not sleeping well, or they're not coping, just double check. And you just ask, in the last 2 weeks, have you had little interest or pleasure in doing things? And how much have you felt down, depressed, or hopeless? You do your little score, and if they score more than 2 or more, then you'll actually go and do your whole 9 questions. You will see how much it's actually influencing their functioning, and then that gives you a score and helps you to actually make a diagnosis as well, get an idea of the severity. What's really nice with the PHQ-9 is you can also use it when you monitor patients. So it's sometimes difficult for a patient, if you've seen them 2 or 3 months down the line, to know how their mood compares now with when they, for example, started treatment. And the PHQ-9 is quite a nice way to sort of take a temperature check in the last 2 weeks. How have you been doing? So let's just look at the suicide risk assessment side of it. And important with depression is we have to do frequent and regular suicide risk assessments. So any patient who's been diagnosed with depression, every single visit, there has to be an assessment of that suicide risk because it can vary throughout the illness. It's also very relevant to understand particular factors that might cause ongoing risk. So some factors are static, so they're not going to change. So if somebody's dealing with a particular difficult chronic illness, for example, that might not change, or there's dynamic or changeable factors. So they've gone through a particular difficult time now, that time is over, and therefore things might change. One of the things that's tempting, and it's especially with all these tools, is that we want to like strategize the risk and give it a number. Watch out to try and say this person is at this much risk of suicide. It's actually very difficult to do that. Much rather describe what's putting them at risk, what they are saying. If they're high risk, you most definitely can strategize that, but I would be very careful about classifying and saying this person is at low risk of suicide. The problem is when they're sitting in front of you, at that moment, they might actually be feeling fine. They might, 2 days later, end up in one of those extreme distress states with that extreme emotional pain. And in that moment, they might actually end up doing something. And so also just from a medico-legal point of view, we have to be a little bit careful about being able to confidently say somebody's not at risk. So there's actually some great tools, and everybody knows the SAD persons. I'll talk about the SAD persons. The SAD person score, yeah, we'll talk about its limitations. And I think the biggest problem with SAD person is, and I think all the scores are like that, it's very difficult to actually exclude risk completely, and one can't really ever completely do that. So most of the tools help us more to identify the person that we have to admit and the person we have to put safety measures in place. But this one is a lovely tool. It's a DOH tool from KZN, a suicide risk assessment form, and it's adapted from the Beck's suicidal intent scale. So it's in particular scenarios. This has been particularly created for patients who has actually attempted suicide. So they've come into your A&E department. They've just had something that they have done to try and end their life. And these are the questions you can now ask to try and get an idea of what their risk is. And you can see, you can actually look at the attempt to give you an idea of how serious that attempt was in terms of how determined that patient was in that moment to actually die. So that includes how isolated they were, the timing of when they did it, what precautions they made to make sure that they won't be stopped, how they asked for help after it happened, if they left a suicide note. You can see how lethal the method was, how serious the attempt was. You can see there's a whole lot of very obvious questions that one can ask, and all of it might not be questions you're asking directly the patient, but you sort of get a good history of what actually happened. And then the degree of premeditation, meditation, etc. So it's a lovely tool, easy to download off the internet. This gives you a score, and you can see they give very clear recommendations. So a low score, it's not like you say they're low risk, you're just saying they scored low on the Beck suicide assessment score, and therefore we can do that as an outpatient support that we can arrange. Medium score, they've got this lovely idea of a community mental health team. How I wish we had community mental health teams. I'm not sure if they have them in KZN. But you want to make sure that there's some sort of support package in place. And if there isn't, these people might be somebody that you actually want to admit. And if they score more than 20, then that's actually a strong indication that patient needs to be admitted. And it might even require, you can make a case then for involuntary admission to keep that patient safe. This is quite a nice screening tool that is useful to have up in all your waiting rooms, and is something that should be out in the communities. And this is actually a way to help people within the community identify suicide risk. So it's questions people can ask themselves. You can see this one has got a nice suicide and crisis lifeline. I'm not sure if that's South Africa. No, that's Colombia. But you can see this gives you a nice way of people starting to be able to notice, oh my goodness, because quite often also what happens with distress is you're in all this emotional pain, your own irrational self is starting to go, I can't do this, and starting to morbidly obsess with finding ways to kill yourself. And it's kind of helpful if somebody then realizes, well, hold on, I'm having these thoughts, I need to get help, and that we can actually intervene early. So this is the classic modified sad person scale. It's also particularly used for emergency rooms. This is not necessarily somebody who's just necessarily attempted, but this can also be somebody who comes in with suicide ideation. Or if you've got somebody with depression and you just want to get some idea of which of these people might be at higher risk. So as we've said, I'd be a bit nervous about complete, or maybe safe to discharge. So if their score is less than 5, you can discharge them, but you need to make sure your safety netting is in place. Between 6 to 8, you at least want to make sure that they're having a psychiatric consultation, hopefully at the time, if possible. But if they score more than 8 on this score, then again, you want to justify for a hospital admission. So particularly for people who have got suicide ideation. So the challenge in terms of deciding to admit or not is that, especially if you're going to have to decide whether you're going to do an involuntary admission, is deciding to make a competency judgment. So remember, we can only do a mental health 72 hours admission, for example, if we think somebody is not competent to make a decision. So with a very severely depressed patient, this is quite difficult because the patient's not psychotic. And they are able to verbally say to you and understand what the outcome is of their decision, for example, to commit suicide. And I think what is helpful here is to understand something that they call the dichotomy of capacity. So when I talked about that survival self that we all have, you can almost imagine that you've got 2 levels of decision making as a human being. So you've got your survival system, who makes decisions only in the present moment of time. And then you've got your executive brain, which is the part of you that's able to make decisions in context and with perspective, and is able to see the long-term implications of something or the wider impact of something. And you can think of that as your you have a rational conscious self, and then you have this irrational emotional self. And quite often those 2 can be in conflict with each other in terms of what they think should be happening next. So suicide is a good example because a lot of people will in that state be within this irrational emotional self. They are in extreme pain. They are not managing, and they're only thinking in the present moment of time, how am I going to reduce this pain? I cannot possibly live like this. Where their rational conscious self, if that was present, which it's not at that moment in time, may not want to die. So what we're actually doing is when we make a decision to admit a patient against their will because of a severely high risk of committing suicide, we're actually overruling their irrational emotional self. And although it overrules their autonomy in that moment, we are assuming that there's a rational person that we are serving, and we want to reduce that risk of harm, reduce them actually doing something which is irreversible, and give them the possibility, once they are their rational conscious self, that one can then really look at what it is that they want or what they need. And as we see with most suicide attempts, people who have attempted to commit suicide, it's not like they keep on trying. They will actually come through that patch, and then at that stage might make a decision of not wanting to die. So it's a little bit how we serve that rational part of the human being. So I thought just before, we're going to go into the actual management of depression, but I just want to talk in general, and also then how do you manage this patient who is in this severe distress, if we've just taken all of these things into account. So this is a patient who might be coming in sobbing, a patient who might have tried to commit suicide, but this can also be somebody who's actually gone through a very traumatic event, be it a bereavement, or themselves been, for example, assaulted, for example, or it might even be a scenario within your own household or family. So when we are dealing with emotion, we are dealing with the survival system of that person. And the most important thing at that time is to give that emotion some safety and some space. So what you don't want to do to emotion is either ignore it or try and fix it or try and minimize it, because that emotion at that stage just needs to be able to actually be. It's that biological impulse. And if you try and suppress that biological impulse, it literally will just get worse. So you don't have to understand the emotion. It doesn't have to be rational. You don't have to agree with the thing that they're emotional about. Think about your 2-year-old throwing a tantrum about the biscuit. But you want to, in that moment, provide them with undivided emotion and attention. Touch is not always appropriate. And if you are going to touch a patient, even if you're just going to put your hand on their arm, make sure you have complete and explicit informed consent. But if you got a loved one or a child, for example, you can also always ask consent, but a hug or that kind of touch, very helpful with people that are close to you. But otherwise, this complete undivided attention, that was not, emotion is not the right word. Yes, sorry, undivided attention to this person and undivided emotional care. Within that space, if the person wants to talk about what's happening, you want to create empathic, active listening. So you don't talk, don't lecture, don't explain, don't try and figure it all out. You use active listening, and you can reflect back to the patient in terms of what you're understanding about their emotions to help them actually express what they are experiencing. The third thing, depending on the scenario, is just creating safety. So remember, it's our survival system that gets kicked in when we feel under threat, and you need to figure out what the threats might be that might have precipitated this particular event. And sometimes there are outside stresses or even stresses within that hospital setting that we can address to create a safe scenario. And then the interesting thing, and this is generally especially before you're going to discharge somebody or when you're starting somebody, for example, on care for depression. There's a beautiful paper about something called mattering. So they've got very good literature now on how important it is for us as human beings to feel that we matter to somebody or to have people that matter to us. And it's a key part of human beings. And one of the things we see within something like depression, for example, is this disconnection from people. Sometimes people might literally just be very isolated, or they might have somebody they care about, but they feel unable because of their emotional state to actually connect to them. You want to be able to identify a key person that's going to be their person. So whether it's a loved one, a child, a parent, and if there isn't such a person in that person's life, then we really have to make sure that they're locked in, for example, with a social worker or a psychologist, or you might even have to see them yourself quite regularly to make sure there is somebody there that is actually seeing and taking care of that person. So let's just quickly talk about the medical management. This is the boring bits and the stuff you all know. So as I've said, do your regular suicide assessments. Please remember to just double check for other things that might be making it all worse, especially your substance abuse. And then we talked a little bit about the psychosocial stresses. So use your multidisciplinary team to start looking at the impact of the environment around them. And then you always just check. There's every now and then, we've just recently got a lovely counselor that's been put into one of our CHCs, and she's quite quiet because people just don't know she's there. So we just need to keep an eye out of key people that can actually provide support for our patients. One of the biggest challenges I find in mental health in general is that we don't explain to the patients what's going on. So informing the patient and the family support system, the patient must be able to come to you and say, I'm here for my diabetes, my hypertension, and my depression. They need to see that as something that's an illness. And I find describing this distress story to them, explaining to them what distress is and how it feels and why it's there and all of that, patients find extremely useful. It's the fact that they've gotten stuck into this particular emotion. Your goals of that psychoeducation is being able to help them understand what it is, and then to look at the self-care coping mechanisms that includes finding that person that matters. And then specifically as there's suicide risk, part of your psychoeducation is, what do you do when you get overwhelmed with distress like that? So we talked earlier about self-harm as well. So somebody who might be in a distressed state, maybe they live on their own, maybe they're stuck within that extreme emotional pain, they need to be able to recognize, oh, I'm stuck within this tunnel right now, and then have a plan. Who do I call? Who do I speak to? What do I do in that moment to manage that particular, that extreme emotion that they're in? One of the challenges is all the myths and misconceptions. Very helpful to find out what your patient thinks depression is, especially for our men. And then the treatment, this is EML stuff, right? So just to remember with fluoxetine, we like to start on 10 milligrams a day, but we don't have a 10 milligram tablet, can't break the tablet. So normally we do 20 milligrams every 2 weeks. And then normally I would write 20 milligrams every 2 weeks. And then after 14 days, you go up to 20 milligrams a day. So if they're quite agitated or they get very agitated on that every 2-day dose, then maybe just go slower. And very important, it does take 4 to 6 weeks for it to kick in. So the patient needs to understand that. But if after 4 weeks you still don't have a proper response on the 20 milligrams a day, go up to 40 milligrams daily. Don't wait. Citalopram is similar. You also start with 10 milligrams a day in the first week, and then you can go up to 20 milligrams quite quickly after that, and also can go up to as much as 40 milligrams a day. So with the SSRIs, particularly the 2 that we have in the public sector, because quite often, sometimes patients in that severe shock state, when you start them on the antidepressants, they're quite numb, they're quite apathetic, they don't even feel anything. And actually, as they get better, they go through a phase of being more agitated and more active. And that's why there's sometimes an increased suicide risk during that first 2 to 4 weeks. So you need to have a lot of discussion around this tunnels one can get stuck in, and make sure that the family is aware and can help keep an eye on the patient. So if your patient is really struggling with insomnia, then you can also use your amitriptyline. Just notice, if you want to use amitriptyline both for sedation as well as its antidepressant effect, the dose is 150 milligrams a day. So the 25 milligrams is not going to do anything for their depression. But the worry always with amitriptyline is that it's so extraordinarily deadly in overdose. So not only when you don't want to give it to your patient who's even remotely suicidal, but you also want to make sure that there's not anybody else in the household that might be able to get hold of that amitriptyline. And just remember our patients who might be at risk of complications. We also don't like using amitriptyline with patients with bipolar, and it's got lots of drug interactions. So helpful for your insomnia patients, but be careful. So our depression treatment is a minimum of 9 months. And you will only stop if there's no or minimal symptoms and functions are back to normal. So actually the definition of a full remission is that for at least 2 months that the patient has had no important symptoms. And then there's some patients where we might give for longer than 9 months. And that's particularly, and I just want to highlight there, if you've got a patient who's had suicide attempts, for example, those are patients you might even consider to have from 1 to 3 years on treatment before you're going to start reducing that treatment. When you decide to decrease your SSRIs, so if you're no longer depressed, the SSRIs don't do anything. So it's not the problem that you stop the SSRIs and the depression comes back, but there's a weird flu-like, almost like a withdrawal symptom, with like flu-like symptoms, weird dizziness, weird dreams. It can be a bit disconcerting. And so we tend to very, very slowly taper the dosing. Actually quite uncommon with fluoxetine, but just to keep aware. We quite often also see patients who come in with quite severe stress disorders after a traumatic event. So something that have happened and they come in this distressed state. And there are definitely places where benzos are very useful in that traumatic event, but be very careful about using benzos for more than a week. So they've actually shown that there's higher rates of post-traumatic stress disorder if you just keep people sedated for long periods of time with their benzos, because they don't actually end up processing what's actually happened. So if you are going to use, what's actually recommended in the EML is clonazepam, 0.5 to 2 milligrams per day in 3 divided dosages, but used for very, very short periods of time. So I would literally give for 2 or 3 days and then review to see where they're at. And you want to get them off that benzos as quickly as possible. For PTSD, or where you think there's a risk of PTSD or there is PTSD, just note that you actually would start on the higher dosages of citalopram and fluoxetine. If you do want to treat insomnia, again, no longer than 3 to 5 days. So we do have oxazepam in some facilities, but again, you will only use it in an acute stress disorder. For chronic insomnia or insomnia due to depression, rather use your amitriptyline. Oof. Okay, it's taking a little bit longer than I thought. I want to focus on bipolar disorder a little bit and being able to make the diagnosis. So I'm going to give you like a very mini version. And as I said, there will be a barcode for those of you who want to get more confident on bipolar. But you have to be able to actually diagnose bipolar in your district hospital setting, have somebody on chronic medication and monitor them for their bipolar disorder. So you'll get 1 and 2, and I'll go through I'm sure most of you will remember some of it, but we'll go through those details in a moment. And it's very much a genetic disease. So it will usually start in youth. If you've got a very much older person having mania, rather take a really good history. Chances are it's been going on for a while, or look for something else. One of the problems with bipolar is, remember, it's a cycling between depression and mania. And so a lot of patients, we might see them during the depressive episodes, and we're managing just the depression, and we miss the fact that it's actually also manic or hypomanic symptoms, and might often misdiagnose these patients. So there's also a high overlap with things like schizophrenia. So take your family histories. And so although you have a genetic predisposition, there's quite a lot of things that then can trigger those first episodes. So substance use, especially cannabis, definitely. Interestingly, trauma. And they've actually linked it to parental loss before the age of 5. Traumatic head injuries can actually trigger something. And then very important, we talked earlier about pregnancy. So watch out for pregnancy, and especially with substance use during pregnancy. And then there's lots of things that can make bipolar worse. So although it's genetic, we really have to look at what other factors are playing a role if we want to manage this well. So for our definitions, I'm going to go through what they all mean. We know what a depressive episode is, but we have to be able to understand what we mean by a manic episode and what we mean by a hypomanic episode to be able to diagnose bipolar. So when we talk about mania, it's also sort of a classic triad. So they always have this very heightened self-esteem, quite grandiose. They have increased motor activity, very, very busy. And they have this very pressured speech, which is actually a reflection of what's happening within their thinking. Mania is always obvious and outrageous. So mania is not going to be subtle, and somebody can't pretend not to be manic, and they can't act normal if they're manic. So if somebody comes in and they're presenting completely fine, and the wife tries to explain to you, actually they were manic at home this morning, but now they're not manic, that's probably not mania, that was probably something else. What's more problematic with the diagnosis is that sometimes the manic can get to the point of being quite delusional. And so people might focus on psychosis and diagnose the patient with schizophrenia or a psychotic disorder and miss that this was actually a manic episode. The manic episode is actually much less than the depressive episodes. So somebody might have bipolar and more often have depression episodes, and the manic episodes are not that common. So these are the DSM criteria for what we mean with manic. And so actually to have a manic episode, you must have happened longer than a week. That's quite helpful with things like substance-induced stuff. So if somebody had a substance-induced with amphetamines and was extremely high for a day or two, but it doesn't last more than a week, we don't actually call that a manic episode. And just notice with the mood, it's elevated, expansive, or it might be irritable. The second thing is a goal-directed activity. So they're trying to do things, and at first they might actually get quite a lot done, although eventually it goes all chaotic. And then this is quite a nice mnemonic of these are three of these 7 things you need to have to be able to combine with these 2 to be able to have mania. So that distractibility, insomnia, grandiosity, flight of ideas, of activities, loud, fast speech, and this loss of judgment, which is usually where the risk comes from. See my interconnection. Okay. So just some caveats. So quite sometimes when this manic episode starts, they've just got this great good humor. They might be very charming. And then as the mania worsens, they become less cheerful, and it becomes a little bit driven, unfunny qualities. So in the beginning, actually, people might just think they've been quite entertaining, and then there comes a point where it's like, no, this is no longer entertaining. Important is that they're not necessarily happy. They can also just be extremely irritable. And they might even have little micro depression. So they might burst out in tears and be very flat, even inside that acute mania. One of the big challenges is that if it's caused by alcohol or substance use, it doesn't count as a manic episode. But of course, a lot of people who are manic use substances, and that can confuse the presentation. So also to be able to classify something as a manic is it must definitely wreak havoc on the lives of that patient and who they're associated with. So it causes lots of arguments. Usually there might be lots of issues in terms of sexual entanglements, financial entanglements. And the problem is that quite often the stuff that happens during the manic episode then compounds the guilt and problems that then comes when they actually hit the depression afterwards. And just remember to exclude medical, psychoactive substances, etc. So how do we differentiate from hypomania? With hypomania, they're not psychotic. So they're also very high, irritable, and expansive. They also have all the activity. Interestingly, you need 4 days to define it as a hypomanic episode, but usually they're not actually impaired as much as with a manic episode, and they can function. They can go to work, they can still get on with things. Sometimes therefore more difficult to diagnose. But if they're not needing admission for their highness, then that's probably not mania, it's hypomania. And again, you can see a similar list of symptoms than the mania, but it does not have this complete loss of judgment. So here's just a table that compares the two, and you can see most of it is very similar, and it's just the psychotic features that's particularly around mania. But hypomania, although there's a change of functioning, there's no need for there's no psychosis, and there's no need for hospitalization. So how do we diagnose it? So the challenge is they arrive at your A&E or in your OPD setting, and they might present as a depression. They might just present with a mania. They might present with hypomania, or they might come in psychotic. So there's lots of different ways, and it's more good just to have bipolar in the back of your mind for patients who present with these very acute. And remember, they will be quite severely ill to present in your emergency setting. Just keep it in mind for people with treatment-resistant depression. So if somebody is depressed and you've been treating them and you've got them on full dose of fluoxetine and they're not getting better, maybe just take a good history to make sure there's no mania or hypomanic episodes in the past. And they might also be brought in not because of their mood, but because they've been causing havoc. So some of their behavior has caused trouble, or some of their substance abuse stuff has been causing problems, and that's actually the reason why they've ended up in your emergency room. Interestingly enough, women tend to present more with the depressions, and men are more likely the ones that the police brings in with some sort of disruptive behavior. So for bipolar 1, it's very simple. They must have had one manic episode. And most would have had a depressive episode in the past, but actually just one manic episode and remember, more than 1 week, that makes you diagnose somebody with bipolar 1. Bipolar 2 is they must have had at least one hypomanic episode, but you must also have had a history of a major depressive episode before we make the diagnosis of bipolar 2. And I'm not going to cover all the others. That's DSM-5 stuff. So when we assess them, you want to be able to decide, okay, is this mania? Is this hypomania? Is this a major depressive disorder? So first diagnose your episode. And I'm going to show you in a minute the Young Mania Rating Scale. Young refers to a person, not an age. And the next thing you want is you want to take a really good history. And there's something called the Mood Disorder Questionnaire, which is a great questionnaire to help patients take a history to figure out whether they might have had manic or hypomanic episodes in the past. So that's quite useful also with your major depressive disorders, just to keep that in mind. Just important, if your patient does have mania or psychosis, is you obviously still want to do a full delirium screen and make sure there's not a physiological cause. So this is what the Young Mania Rating Scale looks like. And you can see there's 11 questions. It's all the typical sort of to do with mood and sexual interest and sleep and speech, content, etc. You get a nice little score. And then that score is going to be able to not only help you identify that it's mania, but it's also going to help to identify you the severity of the mania at the moment. And again, that's very useful if you're going to start the patient on treatment and somebody else is going to follow up the patient on the ward to be able to have some sort of idea of how they are responding to treatment. So this is the Mood Disorder Questionnaire. So there's, and you can see here in question 1, there's like 13 little sub-questions, and you can see it's quite clever questions like, have you ever spent money that got your family into trouble? Have you felt much more self-confident than usual? So it's a nice little thing you can chat to the patient about, and in a hypomanic patient, you can actually have a conversation with them and start getting an idea of whether there might have been a hypomania or a mania either at the present or in the past. So for bipolar, number 1, a manic episode, as I've said, must be more than a week, and just make sure that it's not due to a substance or medical condition. For bipolar 2, usually they don't need to be hospitalized, and most of them, they will have quite severe major depressive disorders, and then the odd little hypomanic disorder in between. Very quite common with the bipolar 2s is that quite often it's precipitated by somebody who's got a major depressive episode. You put them on fluoxetine, and then they suddenly come in with hypomania, and then you realize, oh, actually this was bipolar. They can also cycle much more, so they go a little bit high, and then they go low, and then they go high, and then they go low, but more than our dysthemias. And it's not a huge part of our population, but again, particularly a risk in the peripartum. So the hormonal changes in the peripartum can actually trigger, especially hypomania. Patients might be ill for much longer and spend much more time in the depressive phase. Obviously, often the diagnosis gets missed much more often because they don't have that florid mania. And these patients are much more at risk of impulsive suicide attempts. And it's be very important to keep an eye on that. So management, we're almost there. So we obviously want to use mood stabilizers. So we're going to use oral medicines to prevent new mood episodes. And this is the core basis of your treatment for your bipolar. It's not actually the treatment of the acute episodes, but it's that baseline treatment of the mood itself. Our best drug is lithium, and we'll talk quite a bit about lithium. Our second best drug is valproate, especially if there's mania, and olanzapine, and then the next two are lamotrigine and quetiapine is better for our hypomanias, but I'll show you that in a minute. And then carbamazepine right down there on the list. So just in terms of lithium, I don't know how many of you have actually used lithium. I think we probably unuse it in the districts. People feel a bit nervous about using it. But actually, if you've got somebody that's manic, that's what you want to put them on. It's the lithium that's going to sort them out, not the antipsychotics. It works very quickly for mania, but might take more longer for a depressive episode. And it's very good also then as a prevention method once they're on that treatment to prevent manic episodes, depressive episodes, but very importantly, it reduces aggression, self-harm, and suicide. So the tricky thing with lithium is you have to do therapeutic drug monitoring because different people's bodies respond differently, and the levels that you're aiming for is going to depend on what you're trying to achieve. So if they've got acute mania, you want to go for a slightly higher level. If you want to prevent a manic attacks, 0.6 to 0.8. And for depressive patients, you're going to use a slightly lower level. Very important, you don't want to stop lithium suddenly because that might precipitate mania. And you might see that with patients who default treatment. So they've been on lithium for a while, they feel really well, they stop the lithium, and then that ends up triggering into a manic episode. So lithium has got lots of potential adverse effects. If you monitor it well, it's not a huge problem. Biggest worry is kidneys, but it can also affect the thyroid and the hyperparathyroid. But particularly worrying with lithium is it can get toxic. And you can see it can cause our typical anorexias, muscle weaknesses, and then there's the very scary seizure, coma, death warning. And the risk of toxicity is increased when something changes, especially. So if the patient suddenly goes to a low-salt diet, suddenly gets very dehydrated, goes running or something, drug interactions, or if they're suddenly going into renal failure, that's going to suddenly push that lithium levels up. So there needs to be some sort of awareness and counseling of the patient. So this brings the question of what do we do with patients with CKD? And it's not as simple as saying, well, don't use lithium, because lithium is such a good drug. And some patients, lithium is the only thing that makes a difference. So apparently you can use lithium in CKD, and you might need much less lithium. And you're going to aim for a lower therapeutic range. So if you do use lithium in a patient with CKD, very close renal monitoring, but probably these ones are the ones you're going to send to the psychiatrist. Just some general measures. I'm not going to spend much time on this. So obviously make sure that what your plan is relevant for your patient. Please remember to check all the other comorbid diseases that might be influenced by all of this. And with our bipolar patients, of all the psychiatric conditions, has got the highest suicide risk. So you will need to constantly do that suicide risk assessment. You got your manic patient in your A&E. What do we do? So usually you would, with your mania, your severe depressions, your psychosis, you want to admit those patients, and you might need to sedate your manic patients. Quite often you have to do an involuntary admission, and obviously you're going to investigate and manage the medical stuff. Very important is you want to start your long-term treatment strategy early, and your strategy must never be just about managing this acute episode, but it's about how we're going to manage the rest of their lives in terms of their bipolar disease. So for the acute manic episode, you can use your classic allopurinol, olanzapine, risperidone, and quetiapine are the 4 drugs we can use for short-term reduction in symptoms. The EML recommendation has actually got 2 recommendations, either short-term sedation with either lorazepam or clonazepam, or you can combine it or combine it with a short-term antipsychotic like the risperidone. So this we can use, especially for that patient who is very restless and very difficult in your A&E, but you want to start the mood stabilizer at the same time, because the mood stabilizer is what's actually going to sort out the mania. This is just managing the acute symptoms for the moment. So you're going to initiate your lithium, and before you initiate lithium, you need to take an EGFR, you need to take your TFTs as well as calcium, remember by that, the parathyroid. And if the patient does have any cardiovascular risk factors, just have a baseline ECG. There's our normal dose, 200 to 600 milligrams at night usually, and we normally start at about 400 milligrams on the average patient. So the tricky bit is that you need to do a plasma trough concentration at least 12 hours after that dose. So you want to, so we're going to give it at night. So usually the next morning you will take your bloods, and then 7 days after each dose change, you want to check what your lithium levels are. And once that's stable, you're going to do it at 1 month and 3 months of treatment, or when anything obviously changes. Very important, if the patient is already on fluoxetine or citalopram, you want to get them off those. There's no place for antidepressants for a patient who's bipolar. So even the depressive symptoms we are treating with the lithium, and you want to just taper and get them off the antidepressant drugs. So this is our 3 lines for the mania, the hypomania, and the depressive episode, depending on how they've presented. You're going to start with lithium. You're going to get them to that, aim for that slightly higher level. For your mania patient, if you can't use lithium for whatever reason, or the lithium is not doing the job, then your second option is valproate or olanzapine. For both hypomania or your patients with depression, if the lithium does not do the trick, and remember the lithium is also going to take a few weeks with depression, but your second line for those are either lamotrigine or quetiapine, and we use slightly lower lithium levels than we do for the manic patients. So this is to treat and then prevent future episodes. For all of these, if none of this works, you will refer to a psychiatrist, and clozapine will be under psychiatric supervision is a third-line option for patients where you're not managing. Most of our patients we're going to try and manage with lithium as our core drug. When the patient becomes euthymic, in remission, you obviously want to taper and stop that antipsychotic drugs. You want to get them off the antidepressants, and then you're just going to keep them on that mood stabilizer, which will be lithium or one of the others if the lithium is not tolerated. So what's very helpful is you can use that Young scale that I mentioned for the mania and the PHQ-9 to monitor how your patient's symptoms are doing. And then just a couple of caveats. Don't combine two antipsychotics, please. And valproate and olanzapine, for example, is not a good combination because of the weight gain. Apologies for being a little bit over. We're almost there. Psychosocial support, and again, I think bipolar is also, it's like schizophrenia. Nobody explains to the patient what it is. And it doesn't the psychoeducation must inform the family and carers, because quite often what you're explaining to the patient, even if the patient grasps what you're telling them, if they go into an episode, especially if they're going into a hypomanic or mania episode, one of the biggest things is loss of insight. So they're not going to know that this is what's happening. So they and their family needs to understand what is the early signs of relapse, what is needed to help keep them steady, what kind of things might trigger them. And there needs to be some sort of custodian curatorship that gets decided. So I, for example, once had a pregnant woman who got psychotic, well, she got manic each time she had a baby, and she'd already had 2 babies and 2 manic episodes. And so she and her husband signed almost like a contract that if she started going high after the baby was born, he will tell her to come in and she will just follow his instructions. And I remember seeing her when she came in, and she was in complete denial. She said, I don't know why I'm here, sitting there with bright makeup. But she was willing to listen to her husband because that was the agreement, and we were able to treat her quickly and successfully. Very important is SADAC has actually got some great support groups specifically around bipolar, and these patients are very vulnerable, both from a self-harm point of view, but also victimization from others, and then also violence and criminality might also be a risk. The social worker and the OT is very helpful to help patients like these integrate back into society. There's a great form called the RuDASA 2, which is the WHO DAS, maybe better way of saying that, which really look at what their particular functioning is like and how that can be better supported. So to monitor our patients, you want to do your monitoring lithium level at eGFR every 6 months, and a bit more commonly, obviously, in our elderly or comorbid patients. I've already put those goals up there. You want to do a TSH and calcium annually, and a cusp and full blood count every 6 months, unless there's a reason to do it more often. And then we're going to do that ongoing mentoring of their mental and physical state. The idea is not to ever stop treatment. So we want to encourage long-term treatment. And you want to especially watch out for an early abrupt lithium discontinuation, because those has got the very high risk of relapse. If somebody's been on treatment for a very long time, it's something they've had when they were younger, or there was something very clear that triggered it, and they do want to try and see what happens if they go off the treatment, or medically there's a reason why you have to take them off it. You want to, again, taper it very, very slowly, and make sure that everybody knows what the early warning signs is. Patients you don't want to manage in your district hospital setting if that person is a very high risk to self or others. If you don't have a safe space where you can keep them. If that cycling is extremely rapid, they might need the clozapine kind of interventions, or if they're not responding to the treatment that you're using. So in summary, make a diagnosis. I think we are very bad at properly putting our heads on a block. You know, we've got all these acute psych patients in our notes. We want to be very clear this is a bipolar 1 or a bipolar 2. Very clear to the family that everybody understands what's going on, and having a very nice long-term continuous follow-up of those patients. Thank you very much. Apparently, apologies that I've gone slightly over. In the top corner here is on the WUSU Family Medicine, the CMH Family Medicine YouTube channel. We have sort of playlists with tutorials that we've been creating for our interns. Those are all the mental health tutorials. It's got much more detail on depression, on bipolar, as well as autism, ADHD, and a few other things. So do go and have a look if you want to go into a bit more detail. Thank you very much.
Wow, thank you very much, Madeleine. And I think that this presentation was very insightful and a comprehensive presentation on acute distress and mood disorders. I think you've been able to unpack a complex topic with such clarity and empathy. I'm sure that all of us that are present here actually deeply appreciate that. It certainly broadens the perspective on managing the mood disorders in our acute setting. So we are very grateful for your time and also your expertise on delivering such a very insightful presentation. So I'll take this opportunity then to actually allow questions, but just to note that available now is actually a poll that is available where you can actually click and mark, and it will end at the end. But for now, can we please take any questions if they are available? I will be looking at the chat box, and then I think Madeleine will be able to take on as well if there are any. If you are able to raise your hand, then please do so as well, and then we will take your question.
I'm also curious about how much you guys are managing bipolar independently within, how much of these patients are being managed within our district settings. I'm not sure if they're getting referred up or if they're just simply getting missed, or if there are some of you that actually has quite good services for especially for your bipolar patients.
All right, colleagues, are there any questions?
I think we're too far after 7.
I think that you were too clear on your presentation, that you've covered almost everything. I myself, I don't treat patients quite a lot, but I've been able to get a lot of information that is very useful from the presentation.
I would like just to also add, with all the reading I've been doing at the moment about emotion, is in terms of how vulnerable we are as healthcare professionals. So, there's a much higher rate of anxiety and depression with healthcare professionals. We've had recently also here in the Eastern Cape suicide of a young doctor. And always my heart goes out with, they with among health professionals every day, and how we can even miss it amongst our, where people can end up feeling so isolated and disconnected. And so I think also for us to be able to look after ourselves and offer emotional support for our colleagues as well.
Awesome.
I see there's a designated facility in the Free State, but they don't have lithium. It's a bit pointless if you've got bipolar and you don't have lithium. So that is something that you could actually consider taking to your PTC. It's like having HIV and not having ARVs. It's such a core treatment.
Wonderful. I think we've given a little bit of time for the questions, Dr. Muller, and I don't see any particular questions. Just on the chat box, I see a lot of appreciations that are there for the presentation that you have provided.
Right. Thank you very much, everybody. Have a lovely evening. We'll keep you posted for the next ramp next month. Definitely not here to remind. Okay, thanks.
Thank you very much, colleague.